Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discussed the vasectomy, one of the most common procedures performed in men, but one that nonetheless is steeped in myths and urban legends. In order to help us separate the facts from the fictions about vasectomies, we turn to an expert. Dr. Jay Sandlow is professor and interim chairman of the Department of Urology at the Medical College of Wisconsin. Dr. Sandlow earned his medical degree from Rush Medical College and then completed both his urology residency and a fellowship in male infertility at the University of Iowa. He served as associate professor at the University of Iowa until 2003, when he was appointed professor and vice chairman of the Department of Urology at the Medical College of Wisconsin. Dr. Sandlow has authored multiple academic manuscripts and textbook chapters and is on the editorial boards of some of the top academic urological publications in the country. And now I bring you our conversation with Dr. Jay Sandlow about vasectomies. Hello and welcome to Better Man Clinics. Today we're going to be speaking about vasectomies, a topic that tends to bring a little bit of anxiety in a lot of men, even though it's such a common procedure. And why does that anxiety come up? A lot of it has to do with a ton of urban legends that keep circulating around this procedure, which again is so common, but definitely brings the anxiety up in men. So today we're going to try to demystify vasectomies. And in order to do that, we've brought the expert on vasectomies on the program with us. Dr. Jay Sandlow is the interim chairman of urology and professor of urology at the Medical College of Wisconsin. And as I mentioned, is the expert in vasectomies. Dr. Sandlow, welcome to the program.
Thank you, Oleg, and maybe an expert. I'm not sure about the, but okay, thanks.
He's too humble, everyone. He's too humble. But we are really happy to have you. And I know we have tons of questions that come up. But before that, just to take a step back, would love to know a little bit more about you. Part of the purpose of this program is that this information is not coming from a generic screen or text or just some quote unquote expert. We'd love to kind of meet the person who's giving us this information. So I always ask a question of what inspired you, A, to become a urologist, and B, to have that passion in this particular topic?
Well, the answer to the first question in terms of how I became a urologist, I knew I wanted to do something surgical. And when I got on urology, it just clicked. Like, you have to have a little bit different sense of humor to be a urologist, as you know, and you have to be comfortable doing uncomfortable things. And, you know, I fit the bill for both of those. And so, you know, the more I got into it, the more I liked it. And I was fortunate enough that I was able to train at the University of Iowa, which is a great place. Stayed there. I was there total for 16 years, and now I've been in Milwaukee at the Medical College of Wisconsin for 18 years.
Fantastic. And you got your Packers jersey for Sunday football. So we're all set and ready to go, which is pretty funny because I hear that vasectomies tend to spike around big sporting events like the Super Bowl or March Madness. Do you find that as well?
I do, but it's actually a little bit of a self-fulfilling prophecy. So this all started probably about 10 years ago. A urology group in Oregon thought that they would have run a March Madness special for vasectomies, and it made for a good story. And then it came out that, wow, this seems like a good excuse to sit on the couch for 4 days and watch basketball. And so every year there's like more and more media attention to that, to the point where now I have guys coming in literally in January trying to book that opening weekend so that they can sit on the couch.
Makes sense. Listen, it makes somebody's a marketing genius, but it does make all the
Right.
sense in the world, doesn't it? Uh,
Absolutely.
Perfect. Well, let's jump into the world of vasectomy. So I like to start at the basics at the beginning, right? Everyone heard of vasectomy, they kind of get an idea, but what is a vasectomy and really how does it make a man infertile?
So a vasectomy is a surgical procedure that's done to basically block the tubes that carry sperm from the testicles out. It's a very common procedure. About 500,000 are done in the U.S. each year, and it's fairly simple. And as we'll talk about, very effective. So that's the bottom line is you're basically blocking the transport system from the testicles on the way out.
Well, that actually sets up my next question perfectly, right? So a question that we hear quite often, here's urban legend number one. So the question we hear a lot is you just mentioned that the way a vasectomy works is we're actually blocking the tube, which is called the vas deferens, that carries sperm from the testicles out. Now, some people would think if you block that tube, all those sperm in that testicle are going to back up. Maybe they're going to float over back into your bloodstream, make you sick. Some bad stuff is going to happen. What happens to that sperm that's on the other side of that cut or the block?
Yeah, that's a great question. I always have to reassure my patients that they're not going to explode. So um, the sperm do travel through the tubing system up to where the blockage is, and they sit there and then they die. And like any other dead cell in the body, your body breaks them down and reabsorbs them. So there's an equilibrium that's reached between the body producing sperm and the body reabsorbing sperm. So while there are breakdown products over time that can build up in that tubing system, the sperm themselves are gone, and there's no you don't get, a backup into the bloodstream or into your head or wherever else people think that they may go.
And just to follow up on that, we're going to be explicitly clear here. So there should never be a feeling of your testicles filling up with sperm or anything like that, where they get like swollen with sperm. That shouldn't be happening normally, right?
Correct. And it's interesting because I think once in a while a patient will come in and say they feel that sensation, but I think a lot of it is, most of our patients are young, healthy men who don't think much about their testicles, and then they have a procedure down there, and now you are aware of everything. So
Yes.
every little ache and pain suddenly seems like a much bigger deal.
Got it. Well, that helps it dispel some myths. That right there, it really helps. Now, one other thing you mentioned again right off the bat is that it's a super effective procedure. Now, if men are going to go and go through the process of having cuts, quote unquote, down there, they really want to make sure it's gonna be meaningful. So, how effective are vasectomies in terms of creating infertility or stopping fertility, however you want to look at it?
So one of the things that I always do is I try to put it into perspective for my patients. And I say, okay, if your partner's on the pill, that has a failure rate of about 3 out of 100, which is actually pretty high. If your partner has her tubes tied, that has a failure rate of about 1 in 700 to 750. So better, but still not great. The best method on the female side is actually an intrauterine device, an IUD, and that'll fail in about 1 in 1,000 to 1 in 1,500. The failure rate for a vasectomy is 1 in 2,000, and that is actually probably a little higher than what most of us experience, but that's what's in the literature, so that's what I quote. But it's probably closer to a failure rate of 1 in 4 to 1 in 5,000.
Well, those odds are pretty good for Vegas. That's if you're betting
Right?
on Sunday
Yes.
football, that's pretty darn. That's a good bet on the other side of it, I should say. Now, so it seems to be pretty effective. What about risks? Everyone worries about that. Obviously, you're working in some sensitive areas. What are the general risks of a vasectomy?
So I tell patients the risks are fairly rare. They include bleeding, infection, chronic testicular pain, and then, as we mentioned, failure. The risks of bleeding and infection are significantly less than 1%, particularly with experienced vasectomists. Although a lot of patients are probably overdiagnosed with infections such as epididymitis, which is really an infection in that in that tubing system. Typically, anyone who comes in complaining of pain or swelling after a vasectomy, they get treated as if there's an infection, even though there typically isn't.
Mhm.
Testicular pain is certainly a risk. I don't think it's super common, but patients do need to understand that anytime you do surgery on an area, there's going to be some scarring and you will feel something. The difference is how it is handled and how patients perceive it. So if you ask somebody, since your vasectomy, have you ever had any discomfort down there? Most men will say yes, they've had, a twinge or an ache or something. But if you ask, since your vasectomy, have you had any discomfort down there that has altered your life, made you stop doing your daily activities? The answer is very rarely yes. It's almost always no. So really true significant post-vasectomy pain is pretty uncommon.
Got it. Got it. No, that helps a lot. And you mentioned tubal ligation a minute ago. So again, the definitive options for men are vasectomy. For women are a tubal ligation, and that's something that couples battle with. Which one is going to get it done. From a standpoint of, you had mentioned the risks of vasectomy. If a couple is, and obviously this, I'm going to preface this by saying it's variable. It depends on the couple. It depends on the circumstances. But on a high level, if you had to say what is more risky, is it a vasectomy or a tubal ligation?
Yeah, so a tubal ligation requires general anesthesia. They can do them laparoscopically now, so at least there isn't a big incision, but you are going into the abdominal cavity, which means you always run the risk of hitting a major blood vessel. It's much more expensive. The recovery is more. And as I had mentioned, it's not even as effective as a vasectomy. Mm-hmm. Most vasectomies are done in the office under local anesthesia, a day or two of recovery for most men, highly effective. But in the United States, there's still 2 to 3 times more tubal ligations done than vasectomies each year, even though vasectomies are easier, less expensive, less invasive, and more effective.
That is amazing. What do you attribute that to?
Well, we're guys. We don't we don't like anybody messing around down there. When push comes to shove, if a woman gets pregnant, it's hers to deal with. I think, as you mentioned, there are a lot of myths out there, and it's interesting. Some of the things that people have heard and believe in terms of it will, kill your sex drive, or orgasm will be much different, or, you won't be able to get erections anymore. I mean, it's really, there's a lot of misinformation out there. And so I think, at the end of the day, women have to take responsibility. And if they can't count on their partner to do it, then they have to do it themselves. But, we really spend a lot of time and effort trying to educate men and couples that vasectomies for the vast majority of couples are easier, less invasive, less expensive, and more effective.
That's actually very important for people to know. And I can't believe I walked into that one. I mean, this part of the reason for this podcast is that you guys usually need to be dragged in kicking and screaming to the doctor's office. So I literally walked into that one for you. Well, there you go. So I think this is a perfect segue. We're going to get some of these myths out of the way. And because I really want to dive into them and maybe even get an understanding of where this is coming from, right? The first one that I want to ask, though, is not related to sexual function. It's one, though, that's really, really prominent. And I've even seen some on the scientific side. The relationship between vasectomies and prostate cancer. Is there one? To what extent? What is your take-home message with this?
So I was fortunate enough to be on the panel that our national organization, the AUA, put together about 10 years ago to establish some guidelines for vasectomies. And one of the things that we looked at was this prostate cancer controversy. This originally came out in the early 90s. It was published in JAMA and it got a lot of press.
Mm-hmm.
It was a huge study that looked at the partners of nurses and other healthcare workers who had vasectomies and found that those who had vasectomies had a higher rate of prostate cancer than those who didn't.
Mm-hmm.
A lot of problems with the study, one of which there wasn't a urologist even on the study. It was run by an epidemiologist.
Mm-hmm.
Two, there were no questions about previous prostate issues. So you're too young to remember this, but when I was a resident, there were still faculty who did a vasectomy with a transurethral resection of the prostate to try to prevent post-op infections.
Mm-hmm.
Well,
Mm-hmm.
many of those men had prostate cancer that was diagnosed on that surgical procedure.
Oh,
so there were a lot of confounding variables. And then the final thing is that when you talk to epidemiologists, when you're dealing with two very common things. So prostate cancer is extremely common. 1 in 9 men will develop prostate cancer over the course of their lifetime, and vasectomies are common. So often it's true, but unrelated. And what you find is that in these epidemiological studies, you need a 2 to 3 times risk before you even really start to get clinically significant. In most of these studies, it's between 1.1 and 1.5 times risk. So there are a lot of sort of other studies done after these initial ones to debunk it. There's no good biologic reason for it, and it probably just didn't seem to hold up. That was fine until probably around 2014 or 2015. The same group actually came out and updated their data and said, actually, vasectomy is not only a risk for prostate cancer, it's a risk for high-grade prostate cancer.
Wow.
And so we actually, it was published in Cancer, and we actually wrote a letter to the editor kind of going point by point why this wasn't true. And again, it died down. There was all of the press was about the link, and none of the press was about the fact that nobody really believes it. So the bottom line is that not only is there not a good relationship between vasectomy and prostate cancer, but as a urologist or as someone who's counseling a patient, you don't need to tell them about it unless they ask about it, because it's just not something that has a really good basis for that relationship.
Got it. No, that's helpful to know, because a lot of guys do ask that question, and prostate cancer is pretty prevalent, and so they think if this is a way to prevent it, if this is going to cause it, why would I get it done? But this is you framed it very, very clearly. I think that makes a lot of sense. Now, let's go dive into the sexual side of things that you mentioned as well, because these are rampant now. And you know what? On the surface, I guess it makes sense, right?
Sure.
You're working around the testicles, sexual organ, penis is right next door. So you would figure that if you're working down there, anything can go awry from the sexual perspective, and guys have discussed things online to ad nauseum about this. So I'm going to ask you point blank. It's like you're on the witness chair. I'm going to ask you point blank, line by line, and we'll see where we go from there. So the first one is, can vasectomies affect erections?
No. And this one's easy because, as you know, the nerves that control erections are around the prostate. And when you're doing a vasectomy, you are nowhere near those nerves at all. You're not near the nerves that control erections or ejaculation. So any erectile issues that occur after a vasectomy are not due to the vasectomy itself.
Mm-hmm. Perfect. Well then, how about this, doctor? But the testicles, they produce a lot of their testosterone, and that drives libido. So surely the libido is going to be affected with the vasectomy, right?
Wrong. So your testicles do not know you've had a vasectomy. They are working just as hard day in and day out, whether or not you've had a vasectomy. All the same hormones are produced, as I mentioned before. sperm are being produced. So if you look, and they've done these studies where they've looked at testosterone levels and other hormone levels after vasectomies and have found no difference. And we know that sperm production continues because when we do a vasectomy reversal, those typically work, which we can talk about later. So I think that, again, while it seems like it might make sense that, gee, you're messing around down there, how does that not affect hormone production? Your testicles are they're cranking out testosterone as if there was no vasectomy.
Okay, maybe you got me there. But this one I think is going to be a good one, right? You yourself said that we're cutting off the tubes that are transporting all that sperm.
Correct.
Now, if that sperm's not coming out, certainly, what am I going to ejaculate then? It's not, the ejaculation has to be different, right?
So the sensation is not different because the sensation of orgasm is again, much different nerves than what goes along the vas deferens. For the vast majority of particularly younger men, there's no change in what comes out. If you measure it, you might measure a small difference after a vasectomy, but the bulk of our semen that comes out when we ejaculate comes from our seminal vesicles and our prostate, and we're not doing anything with that. The caveat there is in older men, and most of these guys already will have a noticeable difference in how much fluid comes out and the force of ejaculation. I will tell my patients in their 40s and 50s, you may notice a slight difference in the amount of fluid because relatively less fluid is coming from the seminal vesicles and the prostate, and so relatively more is coming from the testicles. So by blocking the vas deferens, you will have less fluid coming out, but the sensation is the same. And so it's very rare that you get a patient who will come in and say, oh, wow, it just isn't like it used to be.
Got it. So overall, we can say that sex, for the most part, basically feels the same before and after.
Sex or the same or better. So there are actually a couple of studies that show that both patient and partner satisfaction are increased after vasectomy, presumably because the worry of an unintended pregnancy is no more.
Good point. The psychological factors is a big one for sure.
Right.
Well, listen, thank you for clearing up those myths. That's for sure. I think that puts a lot of listeners and viewers at ease. Now I'd like to dive into the actual logistics and details of the actual procedure. First of all, if you look online, there's a lot of marketing for different types of vasectomy, right? There's the conventional vasectomy, which always gets a bad rap, when marketing, but they talk about, for instance, no scalpel vasectomies or minimally invasive vasectomies. And then there's the inevitable discussion about one incision versus two incisions and which is better. Can you comment a little bit about the different approaches to vasectomy and if you think one is better than the others?
So that was a big part of what we did with these AUA guidelines was we looked to see, are there types of vasectomies that are better than others? I will say that over the years, I think what we call the conventional vasectomy has definitely changed. So back in the day, you would make, because urologists were surgeons, you would make an incision and then you would dissect down to the tube to the vas deferens. And then you'd bring it up and you would tie it or clip it or whatever. And there was a lot more bleeding and swelling and pain after that. In 1972, a Chinese physician, Dr. Li, came up with what was called the no scalpel vasectomy, where he actually brought the vas deferens up to the skin, anesthetized the skin, made a small hole, clamped the tube, made a small hole, and then brought the vas deferens out through that. When we were coming up with the guidelines, we used the original description of the no scalpel vasectomy as our definition of no scalpel vasectomy. And everything else after that was considered a minimally invasive vasectomy as long as the hole or the incision was less than 1 centimeter. So how the vasectomy itself is performed, meaning how you divide the vas, that is the same whether you are doing it with a small hole, a small incision, or a large incision. So it's isolation and delivery of the vas that makes a big difference. And what we found was that there was significantly less pain, significantly less complications in patients who had either a no scalpel or a minimally invasive vasectomy over a conventional. What I'm finding though is now, because these guidelines have been in place for 10 years, and so there's a whole generation of urologists that are being trained with these new guidelines. Most people who don't actually say they're doing a minimally invasive vasectomy probably are.
Right.
Most people, right? Like most urologists are not making incisions bigger than a centimeter. And so, I think you hit the nail on the head. Marketing is huge, because for guys, we want the least invasive, least painful. And so if you can market yourself as a no needle, no scalpel, minimally invasive vasectomy, that sounds a lot better than, what we saw our dads go through with, tons of bleeding and bruising and purple basketballs down there.
Certainly. And I mean, again, just to summarize what you're saying, kind of regardless of what it's called, based on today's standards of practice, basically everybody's doing a minimally invasive vasectomy, because at the end of the day, these incisions are a centimeter, which basically it's like less than half an inch, more or less, one or two of them. And that, for all intents and purposes, about as minimally invasive as you're going to get.
And we actually looked at one or two incisions and found that there's really no difference. So it's really up to the individual surgeon to decide what works best for them and what works best for their patients. Personally, I prefer two, one on each side, because I like to go as high up away from the testicle as possible. I also like to bring the vas deferens up wherever it's going to come up the easiest with the least amount of discomfort to the patient. When you make one hole or one incision in the middle, you're basically committing both sides to the same hole. Having said that, I've certainly done them, through a single hole in the middle, and patients do extremely well. So it's really more dealer's choice. It's the comfort of the surgeon. Is nothing there. There's no right or wrong when it comes to that.
I think that's such a good point. I always, when patients ask me, I always tell them, like, for you, that one or two incisions isn't going to make a darn bit of difference, because those things are going to get buried in your scrotum and you're never going to see them again. But for the surgeon, it makes a difference, because he or she may be comfortable with one or the other, and that's going to make a big difference in how comfortable you are during this procedure and how quickly it goes, right?
Exactly.
So perfect. So, one other thing about, just before we dive into the procedure, what about preparation? Do men need to do anything to prepare for a vasectomy?
No. So I tell guys, if they don't typically shave down there, don't let this be your first time. Like, you don't let the professionals take care of it. I do tell all my patients to eat, because I think they're less likely to get vasovagal if they have something in their belly. We always make patients have a ride, just because young, healthy guys are notorious for getting vasovagal, where they feel faint and can actually pass out. You wouldn't want that to happen after, on your way home if you're driving. But otherwise, we don't tell guys they have to ejaculate or refrain from ejaculating right beforehand. And there's no like specific grooming that needs to be done.
So now I'm going to dive in really deep into kind of the procedure, because the reason I'm doing this is not just for intellectual curiosity, but as you mentioned, guys are really wary and they get themselves worked up into a frenzy going to these procedures. And what I'd like to do here is just really make them understand exactly, with variation, what to expect.
Right.
Now, you mentioned earlier, these vasectomies are generally done in the office. Does that mean they just go into basically in an exam room, lie on a table, and go from there? Is that kind of what the experience is like, or is it like an operating room in the office?
It depends. So, for instance, I work. My main office is a hospital-based clinic where we do a lot of procedures. So we have these little mini ORs. That's where I do a lot of my vasectomies. but I also go to just a regular doctor's office, and we have a small procedure room there. And I do them in operating rooms as well, just because of the availability. So they can be done pretty much anywhere, particularly since most vasectomies are done under local anesthesia.
So that leads to my next question. Local anesthetic. What does that exactly mean, and how is it actually applied?
So that's the numbing medicine that like you get when you go to the dentist's office. For most patients, it's given through a small injection. I like to use a 30 gauge needle. Some people use 27. So the larger the number, the smaller the needle. I think the smaller needle has less discomfort. There is something called a MetaJet, no needle injector, which uses forced air to kind of pop the local through, and some guys will describe it as a flick. It's really good for patients who don't like needles. Interestingly, if patients don't really care, I've done one on one side and one on the other, and half the time they say that the needle was better, and half the time they say the no needle was better. So again, I think a lot of patients come in, thinking, oh, well, no needle sounds a lot better than a needle, so that's what they want. If someone asks for it, I'll give it to them. It's not a big deal. It's a small little device that is not very expensive. People have looked at things like EMLA cream, where you put a numbing cream on the scrotum before you give the injection. The problem is the injection itself, it's not the skin. It's underneath the skin around the vas where it's uncomfortable, and the EMLA cream won't block that. So there have been lots of studies done. Most of the studies have shown that the anesthetic is probably the worst part, but on a scale of 1 to 5, with 5 being horrendous pain and 1 being no pain, it's usually between a 1 and a 2 is what most guys rate it.
And that's what you mean is the pain during the procedure?
Not even just the pain of getting the actual anesthetic. Once the anesthetic is given, and I always tell my patients, once I've given you the anesthetic, you should not be feeling anything sharp or really uncomfortable. And if you do, tell me, because I will give you more. This is not, I don't look at this as a test of strength or willpower or how much you can put up with. I always tell patients, we're going to tell your partner that you suffered greatly. No worries. Okay. So we're going to play it up. I'll write extra things on their discharge instructions about how they can't do anything around the house for a few months or no childcare duties. But really, the goal is to make this as painless and as we don't want it to be a horrible procedure.
Understood. That makes a lot of sense. So assuming they're, hopefully they're not feeling any sharp pain down there, anything like that. Are you feeling anything during this procedure? Do you feel any pressure? Like, what do you, like at the dentist's office, I get numbing medicine and they're doing, let's say, a root canal. I'm still feeling things moving around and pressure and pushing. What are we feeling during a vasectomy?
So there's certain things you can't numb up. You can't numb up that pulling or tugging sensation. If a patient tells me that they're having a really bad squeezing sensation, like somebody's got their testicle, squeezing, I'll stop and give them more local, because you can usually numb that up. But I think the initial discomfort of somebody kind of pulling down there or tugging is probably the worst. And again, for most guys, they say it's really not that bad. One of the things that I try to do is I always examine my patients in the office before I do the vasectomy, to give them a sense of, here's what you're going to feel. And some men do not tolerate isolation of the vas very well, or they may have a very difficult exam.
Yes.
So I'd rather identify those guys ahead of time and, give them some IV sedation with an anesthesiologist, as opposed to, torturing them in the clinic. But I would say that that's way under, 20% of my patients. It's probably closer to maybe 10%.
Agreed. That makes a lot of sense. So it doesn't sound like it's too terrible during the procedure, but how long does the procedure actually take? How long does it take from start to finish?
For most experienced vasectomists, it's about 15 to 20 minutes. You can do them faster if you're motivated to do so, or you can take longer. With my practice, I have two different rooms. They can't turn the rooms over any quicker than every half hour. So 15 to 20 minutes works out well for me. But I do know some very busy vasectomists who probably do, 3 or 4 an hour.
Wow, that's
Yeah.
quite a turnover, that's for
Yeah.
sure. So okay, let's say I was brave, I'm a superstar. You put in my discharge summary that I got 3 stars for Medal of Valor for my efforts of getting my vasectomy. What am I going to expect walking out that door from your office?
So walking out the door, not much, because you still have the local anesthesia. I use a mixture of lidocaine and bupivacaine. So lidocaine is immediate action, but only lasts for about 30 or 40 minutes. Bupivacaine, though, is a longer acting anesthetic, lasts for typically around 4 or 5 hours. So you should be able to get home relatively pain-free, throw some ice or, frozen peas on the area, and start taking anti-inflammatories, ibuprofen, Tylenol, that kind of thing. So that I tell guys they're going to be achy. They're not, you shouldn't have horrible pain. It's more an achiness like you got hit there yesterday. And so they're still kind of sensitive. Something happened, but it's not like terrible, gut-wrenching, doubled over kind of pain.
And how long is that achiness expected to last?
Anywhere from a couple of days to a couple of weeks. Everybody is different. One of the things that I really make a big deal of is wearing good support. So we give everybody a jock strap, but compression shorts work well. The more support you have, the better. And sort of the analogy that I use is, think about 2 bowling balls suspended by ropes. If you fray that rope a little bit and the bowling balls are just hanging, there's going to be a lot more tension on it than if you bring them up so that there isn't quite as much tension and inflammation on the area that you work.
Makes sense. Do in your practice any restrictions that men need to take after a vasectomy?
So ideally, I would like guys to take it easy over the weekend. So I do a lot of vasectomies Thursdays and Fridays. I don't tell them they have to be bedridden, but we certainly don't want them out there mowing the lawn, shoveling snow, building a house, anything like that.
Sure.
And so that, again, that's why things like March Madness, Super Bowl, the Masters tournament, those are great weekends to do vasectomies, because guys are being told you need to sit on the couch with your feet up and ice packs. I do ask them to refrain from ejaculating for about 5 days, just to let things kind of heal. And I usually have them take about a week off from exercise, heavy lifting, that kind of thing.
Sounds reasonable. What are, again, assuming, we most of the time everything goes well, there's no problem, you're 5 to 7 days later, you're in good shape. Are there any red flags that guys should look out for after vasectomy where things aren't going so well?
So again, given the fact that we're doing a minimally invasive vasectomy, there should not be a lot of bruising. So guys hear about the fact that, you're going to have a softball down there, everything's going to be purple. I tell patients, you shouldn't see more than about a $50 size bruise around each little hole that I make. So I use a little clear plastic Tegaderm, like saran wrap, over the little holes. And I tell patients, if your bruise goes outside of that, I'd want to know about that. You shouldn't have much swelling. So if you start to lose the skin folds in the scrotum, I'd want to know about that. Pain that isn't being handled by Tylenol or ibuprofen, again, that's not normal, and I would want to know about that. So we write down a lot of things to look for, so that patients can be comfortable calling, because a lot of guys, I mean, on the one hand, they're nervous about everything that's going on down there, but on the other hand, they don't want to seem like, oh, I'm overreacting. And so I don't want them to feel bad about calling and letting us know what they're experiencing.
Makes sense. Those are good pieces of advice for sure. Now let's move away from kind of the recovery to kind of what to expect in terms of efficacy. Now, a lot of guys think that once you get a vasectomy, the minute you walk out the door, you are sterile. You're ready to go. Is that the case?
No. And we hammer that home that, it takes a while. One of my patients gave me this analogy. This is the best analogy I've heard. When you turn off the water main to your house, you still have to run all the faucets to empty them out.
That's a good point.
Right? Same thing. So we may be causing a blockage, but you've got to get rid of all the sperm that are in the system. Mm-hmm. Now, I've had some very motivated patients who've tried to do that in 2 or 3 weeks. They've read, hey, 25 ejaculations, and I should be clear. And they figure, okay, 25 ejaculations, that's nothing. I can do that in a couple of weeks. But there is some data to show that there is an early failure rate where the two ends can heal back together within the first 4 to 6 weeks. So we don't even check before 8 weeks. And that's in the guidelines. We specifically say, you really shouldn't check before 8 weeks. Time is more important than number of ejaculations, but number of ejaculations is important. The more you ejaculate, the quicker you're going to empty everything out. So if somebody is, let's say they want to get their wife off of birth control as quickly as possible, or they want to quit using condoms, I tell them, look, we'll check it at 8 weeks, but you need to make sure that you try to empty the system out.
Makes sense. Now, you said we're going to check. What are we checking and when?
So we send everybody home with a sample cup so that they can collect a semen sample at home. And then we have several labs where they can drop it off. We actually give them a date to put on their calendar, not that they need an appointment, but more just to remind them, hey, it's time to check. Mm-hmm. There are some countries where they mail the sample in, and the only downside to that is that if there's any sperm at all, you can't comment on whether or not the sperm are moving. So we defined in the guidelines that you can be declared sterile if you have no sperm on one sample, or if you have what we call rare non-motile sperm. So that is basically less than 100,000 sperm per milliliter that are all non-motile, but that has to be a fresh specimen. So basically what I do is I tell most guys, bring your sample in. We'd like it to be fresh, but if we don't want you killing yourself to get it in, because if there's no sperm, they're fine, right? Sperm don't disappear.
Right.
If they do have sperm though, and they collected the sample, let's say 4 or 5 hours ago, then I will have them repeat another sample fresh so that we can see whether or not there's any motility. But that's pretty rare that we have to do that.
But the bottom line is, until you hear from the doctor that did your vasectomy that your semen analysis is clear by whatever definition is being used, you're for all intents and purposes still fertile. Is that correct?
Exactly. And there's a little bit of debate about that, because there's some evidence that, well, if you do a vasectomy the way that it's described in the guidelines, and there's a huge variety of ways it can be done. So it's not like just one way. But if you use a way that's been proven to be effective, theoretically, you shouldn't have to know, you shouldn't have to check. But we do know that no matter how well you do a vasectomy, there are going to be some failures. The other thing is that the tolerance for failure of a vasectomy is much lower than the tolerance for failure of anything else. And that's just because I think as guys, we're going to do it. We want to make sure it works. Yes. So, you don't see, women don't get don't necessarily have x-rays to make sure that their tubal ligation work. It's just assumed that it worked.
Right.
And the same thing with, with the pill. We tolerate a very high failure rate for the pill. If vasectomies had a 3% failure rate, we wouldn't be doing vasectomies.
Agree.
Right?
Never. Guys would literally be out with pitchforks and torches out by our offices if that was the case. I would imagine. Now, to that extent, vasectomy is a big decision. It's you're becoming sterile, but is vasectomy truly permanent, or in some cases, can it be reversed?
So that's a great question, because when we have a separate form that our Medicaid patients have to sign, and on the form it specifically says that they understand this is considered permanent and not reversible. And that's actually not true. Vasectomies are definitely reversible, and we consider them to be permanent, but we also acknowledge the fact that life changes. And I've done reversals for pretty much every reason you can think of. Obviously, the most common one is a new partner, but I've had couples who've changed their mind. I've had couples who unfortunately have lost a child and want to get pregnant again. I've had patients who had their vasectomy done when they were single and didn't have any children, and then they met somebody and they decided they did want children. I've had patients who just don't feel right after their vasectomy and want to have it reversed. Mm-hmm. And so I don't do anything to make the vasectomy irreversible. I've had patients who've told me, well, my doctor said he was going to make sure this could never be reversed. And what we found is that when you take out, like, instead of 1 centimeter of vas deferens, if you take out 4 or 5 centimeters, the complication rate goes way up. And so, and the effectiveness really doesn't change much. So there's no reason to, do an overly aggressive vasectomy with the thought that, well, if I don't do this, that my failure rate is going to be too high. If your failure rate is high, it has more to do with your technique of what you're doing to divide the vas and less about how much you're actually taking.
Well, that makes sense. Now, if a guy decides he wants to get a vasectomy reversal, like, what is a vasectomy reversal? What's involved with that?
So unfortunately, it's a lot more involved than just the vasectomy. So as I mentioned, the vasectomies are typically, they take 15, 20 minutes. They're done under local anesthesia in the office. Recovery is just a couple of days. A vasectomy reversal, for the most part, is going to take 2 or 3 hours because a good vasectomy reversal is done using an operating microscope. Sutures are used that are finer than your hair, so very, very small sutures and needles. I prefer general anesthesia just because you don't want the patient moving. There are some people who do reversals in their office under local, but they are a little bit limited as to what they can do. And recovery may be a little bit longer depending on what you find and how much dissection you have to do. So, what I tell patients is this: I'm not going to do anything to make your vasectomy irreversible. It's unlikely you're going to change your mind, but if you do, reversal is a very good option.
And if somebody chooses reversal, what type of success rate should they anticipate? And obviously, I'm going to preface that with, it depends on the patient, it depends on the partner, it depends on a million different things. That understood. But in general, like the quoted rates of success for vasectomy reversals.
So what I tell patients is the chance of getting sperm back in the semen, if you go to somebody who does a fair number of reversals, probably in the neighborhood of about 90% chance of getting sperm back, but that's not pregnancy. Mm-hmm. Pregnancy is probably more in the neighborhood of about 60 to 65%. It can be higher, it could be lower, depending on all the things you mentioned: the age of the female partner, how long it's been since the vasectomy, the type of procedure you get. There's a couple of different types of vasectomy reversals based on what we find at the time of surgery. And so when I counsel couples about reversals, I try to tell them more about patency rates, the chances of getting sperm back. I try not to get too detailed about pregnancy rates because there's so many factors that go into that.
Makes sense. And, of course, money always comes into play with this. So two somewhat, well, one is not a very sensitive question. Vasectomies are usually covered by insurance. Are vasectomy reversals?
Rarely. So probably certainly less than 10%, in at least in my practice. Whereas vasectomies, I would say probably over 90% are covered by some type of insurance. I'll put a little plug in here. I think Massachusetts maybe has a mandate where vasectomies are just covered 100%. You don't have to go towards your deductible or anything. I really feel like that's how it should be. We should not, patients, I have so many patients who end up having to pay out of pocket for their vasectomy because they have a high deductible insurance policy. And so vasectomy is covered, but it's going to cost them $5,000. And that's just, that's crazy.
Right.
Reversals, on the other hand, in the vast majority of cases, it's elective, and it is something that very few insurance companies will cover. So, you have to take into consideration the costs of the reversal when you're looking at things. Although, as I always tell patients, you have to be a little bit careful. Sometimes you get what you pay for.
No, for sure. And that, not to put you on the spot here, but so this is an important question, right? Because a lot of guys say, okay, well, Dr. Sandlow just said it's reversible. So what's the big deal? I'll make up my mind. I get a vasectomy. Okay, so I'll get it reversed. Bada bing, bada boom, no problem.
Or as Michael Scott would say, zip, zap, zip, zap.
Right there you go. But generally speaking, and again, it's different across the country and people are charging different things, but like, what type of investment are people setting up for if they're truly going to be reversing a vasectomy?
Well, so the only other option besides a reversal is to go through in vitro fertilization with some type of sperm acquisition. And so in most practices, that's probably going to be about twice as expensive as a reversal. So like I said, you can certainly find reversals that are $3,000 or $4,000 that are usually going to be done in the doctor's office. But I would say that for the majority of the experienced vasectomy reversal, providers, that it's probably somewhere in the $7,000 to $10,000 range, and IVF typically is going to be between $15,000 and $20,000. So the problem is that with a reversal, you can get sperm back and you may still need to do in vitro. So it's, that's again why you have to look at the entire picture. You have to look at the couple. If the partner is 42 years old, well, no matter what you do at 42, it's going to be, less successful than if she's 32.
Of course. And either way, I think the important take home message here, whether it's 3,000 or 7,000 or reversal or IVF, this is hardly bada bing, bada boom. If you need to reverse it, I mean, is it doable? 100%. And that's a lifeline for a lot of people. And especially if you're talking about tragic scenarios or even life changes, but it's not one of those things that you can flippantly just turn off and on and off a switch and just say, hey, no big deal. We'll just reverse it.
Yeah.
Now, to that extent, I'm just going to ask you a very weird question. So, a lot of men who have testicular cancer, they bank sperm beforehand in case they need it. Have you ever heard of banking sperm before a vasectomy? And would you recommend it?
Yes and no. So yes, there are actually some urologists who are very adamant about banking sperm. Interestingly, at least a couple that I know own the sperm banks. So I think there may be
I can't imagine why they would.
Right?
Yes.
I typically don't recommend it. And I want to know why someone wants to do it. So if they say, well, I'm just not sure, and if I change my mind, I don't want to have to go through a reversal. I say, well, first of all, if you're that unsure, then a vasectomy is probably not right for you. Second of all, unless you bank a ton of sperm, you're probably going to end up having to do in vitro fertilization with it. So it's still going to be more expensive than having a reversal. There are some patients or some couples who say, you know what, for us psychologically, it just helps to know we've got something in the bank. And then I say, sure. I mean, then it's worth it because you're getting a psychological benefit from it. But once I tell them about reversals and IVF, for most patients, that reassures them that, while they're doing something that's, quote, permanent, they're not burning a bridge that can't be rebuilt.
That's a great answer. Now, the last thing I'm going to ask you in terms of vasectomies is choosing your vasectomist, the person who's going to do your vasectomy. Now, you mentioned at the beginning, you said there was something like 500,000 vasectomies performed in the country, extremely common. My own experience, I see it's not just urologists performing, you have family medical doctors, gynecologists, general surgeons, you name it, everyone's performing vasectomies. They're marketing it. What would you recommend in terms of when a guy is looking to have a vasectomy done? Let's say they don't have a urologist, they're a young, healthy guy. What are they looking for? Are they looking, I'm just going to throw out some things. Are they looking for somebody who does a ton of them, do thousands of cases every year? Are you looking for specifically a urologist? Are you looking to ask them about their success rates? Like you said, one in several thousand failures. Is that something you ask? What should men be looking for and asking of a potential vasectomist?
That is a great question. The United States is fairly unique. Mm-hmm. In most other parts of the world, urologists don't do vasectomies. The only vasectomies that urologists do are the ones in the operating room. So if you live somewhere outside the United States, don't go to a urologist because they don't want to do it in the office. They're going to put you to sleep for it. Right. They're the general practitioners. Do the bulk of them. In Canada, most of the high volume vasectomists are GPs, same in Europe, or they're gynecologists because they're taking care of contraception. But in the United States, urologists perform about 75% of the vasectomies. There are some very good family medicine docs and even some gynecologists and general surgeons that probably do a lot of them. I think in this day and age with Google and Yelp and health grades and all these other things, that's a great way to find somebody that is reputable, because it used to be that the only people who kind of rated you or evaluated you were the people who were angry or had a bad experience. But now everybody wants to go give somebody 4 stars or 5 stars. It certainly helps if you know someone who had a vasectomy from a specific person, but I'd still look that person up. A lot of the insurance companies now actually have their physicians rated based on patient feedback. So it's not just, here's who's in your network. It's here's who's in your network that our covered, patients have chosen. So, I've been in Milwaukee long enough now that I have a lot of word of mouth referrals. It's amazing. If you do one police officer or one firefighter, you're going to do their whole precinct or their whole firehouse. They'll send one poor guy out to sort of be the scout and see how he does. And if he does well, they'll all come to you. But I think for somebody who doesn't have any connections, a Google search is not a bad way to go. And you do want somebody who does a fair number of vasectomies.
Yes.
If somebody, so you don't want to know how many they've done in their career, because if they've been practicing for, 20 years, but they've only done, 10 or 15 a year, that sounds like they've done several hundred, but they're not doing very many. Right. You want somebody who does, probably at least, between 5 and 10 a month at least, maybe more. I mean, again, at what point does it, some people, this is all they do, and others, they do a lot of other things, but you want someone who does a lot of vasectomies. I really feel that as a patient, I would educate myself about our AUA guidelines and ask them, do you follow these guidelines? Because what I have found is that the people who don't follow the guidelines are probably using outdated procedures with higher failure rates and probably higher complication rates. But I think that the internet is a good source for finding a good vasectomist.
No, that's a great idea. And so for this, they could just Google AUA guidelines potentially and
Yes.
print
Yep.
them out
Yep.
and show.
Right.
Got it. Well, Dr. Sandlow, thank you so much for some great answers. I think you helped to demystify the world of vasectomies quite a bit. I'm going to leave our interview not with a question about a vasectomy, but something a little bit different. We started with you. We're going to end with you too. The title of this series and podcast is Better Man Clinics, and it's beyond just medical. It's all about being better, right? Living your best life. So a question I often ask of my specialists or my experts is, what's your key to success? How do you live your best life?
Wow, great question. I try to do things that keep me involved and keep me happy. So, I've always been involved in the teaching aspect of medicine. I was raised by an academic physician, and I think that, it's part of our duty as physicians to educate the next generation. I think podcasts like yours are excellent because, you're giving legitimate, good information to people from, I think there's so much misinformation these days and everything is sort of treated the same, but I think we need to get back to, treating everybody the way we want to be treated. That's what I teach my residents. Patients are not just cases, they're people. Think of them as if they're your dad or they're your grandfather. Would you want somebody just, treating them a certain way? So that's kind of how I try to live my life.
Well, I think that's great advice, not just for residents, but really anybody out there, the age-old advice, right? Of treat others like you want
Right.
to be treated yourself. With that, Dr. Sandlow, thank you so much for joining us. We've learned a lot. And for everyone viewing and listening, thank you. And remember our mantra here at Better Man Clinics, your best life is a journey and not a destination, and use every single day to get just a little better. We will see you next time.